Welcome back to the Rebel Core Content Podcast. This is Swami, and I'm here today with PEM specialist Dr. Elise Perlman. Elise, welcome to Rebel Cast.
Thanks so much for having me back. I'm so excited to be here with you and everyone else today.
We're very happy to have you back. And today we're going to kind of dive into something that all of us are already elbow deep in, and that's viral season in the pediatric population. Now, the adult side, we're also elbow deep with all of those viral syndromes, but we're going to really focus on the infants and the babies and the toddlers and the little kiddos coming in with fever, cough, and trouble breathing. For everybody out there listening, you already have seen 40 or 50 of these patients. And we are not here to tell you a comprehensive way to approach all of these kids. But we want to give some pearls when you're going in because while most of these kids have some random virus that you're never going to figure out what it is, some of them have more sinister pathology. And the way that we can find those really bad pathologies is to have those little pearls, those little tips and tricks that you have gained over your career in emergency medicine and in pediatric emergency medicine. So are you game to kind of share with all of us your pearls, your little tips and tricks?
Let's get going. I'm
Pearl
sorry.
number one that you gave me is look at your patient.
Absolutely. So, some of the best respiratory exams can actually be done from the doorway before even entering the room because patterns of respiration or use of accessory muscles provide us with a great deal of information. We are so used to saying the term, a patient has increased work of breathing. And when I'm working with a resident, I always make it a point to ask them specifically, what do you mean? Because the type of work matters in your assessment to treat the underlying pathology, which is really what we care about. So you can have work of breathing on inspiration, expiration, or even both. Inspiratory work means it's hard to get air in. So you're using accessory muscles such as your SCM, your scalenes to ultimately lift the sternum, while expiratory work means it's hard to get air out. So you're using accessory muscles such as your abdominal muscles to push with more force. Remember, isolated tachypnea, so no work of breathing, really without fever, URI symptoms, may not be respiratory at all. So for those patients, think outside of the box. Could this be a primary acidemia, increasing your ventilatory drive? Could it be a pneumothorax? And in the right patient, a PE.
All of these things are really important to consider. That idea of the increased respiratory rate or shortness of breath with clear lungs or the atypical presentation that we're seeing right now. You have to think about pulmonary embolism, anemia, a lot of things that you considered. This is the pattern that we see with those kids with DKA, that metabolic acidosis with the compensatory respiratory alkalosis. So when the patient's respiratory rate is increased, just kind of think broadly. And I think that's one of the major take homes here is it's so easy to get lost with all of these patients thinking every kid has a virus. But as soon as we kind of lull ourselves into that false sense of security, we miss the really bad stuff. So some great reminders, make that eyeball assessment from the door before you go in, before the kid sees you and can react to you. All of those are really important. Your pearl number two is to localize the sound.
So, localizing the sound is incredibly important in what we do. So, like we said, respiratory season is upon us, and more often than not, parents are coming in saying the exact same thing. My child has fever, cough, and noisy breathing. However, this noisy breathing, which is effectively saying the same thing as obstructed airflow, is not all created equal. So, in order to localize the sound and identify the underlying pathology, again, which is really what we want to do so we can treat it, we have to understand some anatomy. So, to get that started, an obstruction located above the thoracic inlet, so in the upper airways, will produce something called stridor, which is generally heard on inspiration as the upper airways tend to collapse as air is drawn in past the obstruction. When we look at these patients, they'll show inspiratory work of breathing proportional to the degree of obstruction. It's hard to get air in. An obstruction located below the thoracic inlet, so in the lower airways, will produce a sound called a wheeze, which is generally heard on exhalation as the lower airways tend to collapse as air is pushed out past this obstruction. When we look at these patients, they will show signs of expiratory work of breathing proportional to the degree of obstruction. So they're pushing air out. If you hear, for example, a silent chest, so there's no movement of air, this patient is so severely obstructed they can't get air in or out, and this, of course, is a very ominous sign. I would also like to point out that stridor is not the only upper airway noise we can hear. Stertor, which sounds like stridor, is caused by nasopharyngeal obstruction. And this produces a snoring sound with what parents will come in and describe as a rattle in my child's chest. These are transmitted upper airway sounds and are not coming from the chest at all. Since stridor is heard on inspiration, it is often confused for stridor. But again, they are not the same thing. Grunting is another sound we typically hear. It is made by exhalation against a closed glottis, and it's the body's very smart and cool way of producing PEEP to prevent alveolar collapse. This can usually be seen in lower airway diseases such as pneumonia, pulmonary edema, bronchiolitis, asthma, and so forth. Importantly to note, though, pediatric patients will often make a grunt sound with fever alone. So be sure to note grunting in conjunction with any other respiratory findings. You might think that they're so severely obstructed they're grunting, but it could just be fever.
It's really important to localize these sounds because, of course, then it points you towards the pathology you're dealing with, and then in turn to what you're going to do to relieve that. If the patient has stridor, there's not enough albuterol in the world to open them up. Like that's not going to be the solution there. And that's why we really have to be careful with what we're hearing and localizing that. Sometimes it just takes a minute in the room, just listening, just being completely quiet, listening to what there is going on, watching that patient, seeing when the noise comes with the cycle of breathing. All of that gives that little bit of information. Don't touch the patient. Just stand there and watch. We're kind of continuing with that same idea of how much information you can get by just being quiet and watching the patient. Let's get to the next step, which is once you localize the issue, you have to actually treat it appropriately. So, how does that differ between the stridor, the stridor, and the wheeze?
So that is, the crux of what we do in pediatrics, like you had just mentioned. A lot of it is just looking at your patient, letting them calm down and assess them appropriately. If they're crying, screaming, they're going to be making every single noise imaginable, and you're not going to be able to know exactly what is going on and what the pathology is. So really, we need to look, we need to localize, we need to determine the severity so that we can treat appropriately. And this in and of itself, and what I'm about to talk about, could be multiple lecture series in and of itself. So let's just briefly talk about some of the bread and butter that we see. So stridor from nasal congestion, which probably 99.9% of the patients are going to come in with, is treated with supportive care and suction. These babies, which is typically the patient population that we'll see, and even infants and toddlers, can actually appear quite sick with significant work of breathing, so using of their accessory muscles on inspiratory effort, especially when they have fever because they may appear more tachypnic, working harder. But these are very generally happy infants, babies, toddlers, and all they really need is fever control and a good suction. But it's important to make sure that you're not missing anything else. Make sure to assess their hydration status. Of course, it's hard to feed when you're so congested. Stridor, for example, from laryngotracheitis, which is also known as croup, is treated in ways to decrease that upper airway edema. So like you said, you can throw all of the albuterol out the world at these patients. It's not going to make a difference. So in our toolbox, we have cool air from outside, steroids, racemic epinephrine, IM epi for your sick patients, and even Heliox with positive pressure, depending on the degree of obstruction. A nice pearl that I like to have, just to add to those pearls, is that in your mild to moderate cases of stridor at rest, if your patient fought tooth and nail against that first racemic epinephrine that you gave, they probably didn't get it at all, and that's why they're still stridulous. So give another while you're really waiting for your steroid to kick in. Now on to wheeze. Wheeze does not always mean asthma. We say in our patients less than 2 years of age, but especially less than 12 months, those coming in with diffuse crackles and wheeze with a history of URI symptoms that then progress to their lower respiratory tract is likely bronchiolitis. And that wheeze is not from bronchospasms, but rather a ball in socket type of obstruction. So that's mucus filling your alveoli. The key in these patients is not to overtreat. There's no evidence to suggest that routine use of bronchodilators, racemic epinephrine, hypertonic saline steroids, and so forth are indicated in these patients. A good suction often resolves the majority of their symptoms. Hydrate them as needed. Give oxygen for sats lower than 90 to 92. And in the right clinical context, you can absolutely discharge that happy, mildly tachypnic infant with good follow-up and return precautions. In these patients, just be sure to check their ears because acute otitis is one of the most common complications that we see. Now, if they're over 12 months of age, especially with a history of allergies and eczema, that wheeze is more likely to be from true bronchospasms that will likely respond to bronchodilators. The goal of our treatment is early steroid use, multimodal bronchodilators, and escalation as needed with IV magnesium, fluids, positive pressure, and the remaining tools that we have.
These can be really difficult to tease apart. Does the kid have asthma and they were set off by a virus? Is this just bronchiolitis? And I don't think that we would criticize anyone if they were like, yeah, the 6-month-old with wheezing and I gave him an albuterol treatment, but they didn't get better. So I was like, oh, it's probably not asthma. Maybe this is bronchiolitis. That happens all the time. I've heard so many PEM people talk about how this happens, in spite of the fact that there are recommendations out there and evidence that says albuterol never works. Don't give these patients bronchodilators. Sometimes you try something, it doesn't work, and that's what actually gives you the diagnosis and tells you what to do next. One albuterol treatment in one of these kids isn't really going to harm people. The key is not to get fixated and say, oh, I just haven't given enough yet. Patient's not responding, move on, take care of something else. I think this is really a great way to think about it in those really little kids. If they've got URI symptoms leading up to it, it's probably bronchiolitis, and they're probably not going to get benefit from that bronchodilator. Really important for us to consider. Let's talk about some other pearls specifically with asthma, because we do see lots of kids with asthma. And then, like we said, we see a lot of kids who are having an exacerbation because of that viral infection. Some of these kids are super sick. They're just simply not getting much of our inhaled bronchodilator into them. And a lot of them, the parents say, oh, I was doing all that at home. I've been giving them the neb at home. I already got them on steroids. They're still not getting better. That's why I'm here with you. So when you have that kid where you're like, the parents have done everything that they could possibly do for this kid, what are you doing next?
So it really all depends on your clinical context. And I totally agree with you that if somebody's coming in and the parent is pretty reliable, they've been giving their albuterol every 1 hour, they've already taken their oral systemic steroids, and they're coming in, they're tachypnic, they're tachycardic, they're satting 85 to 90%, they're not speaking in full sentences, they look like they are in so much distress, an early adjunct that can be given in what we're now going to call very severe asthma exacerbation is IM epinephrine. It works systemically to bronchodilate. You want to reach for these in your severely obstructed patients, like we just mentioned, barely moving air, silent chest, incredible work of breathing. Your nebs in these patients are not going to work if they're not moving any air. You're basically just nebulizing into space. So it's always important to remember what we're giving, how much to who. So in our kids, less than 30 kilos, right? That's your Epi Junior. That's 0.15 milligrams. And in your older patients, greater than 30 kilos, we give your regular EpiPen that's 0.3 milligrams. And of course, if you're drawing it up on your own, which is absolutely reasonable to do if that's what your institution does, that's 0.01 milligrams per kilo of the 1 milligram per 1 ml concentration, and you max out at 0.5 milligrams. It's an amazing medication. Don't hesitate to give it. If you're thinking about it, your patient is sick, they need it, go ahead and administer it sooner rather than later.
Such an important take home point. IM epinephrine, or we should really say parenteral epinephrine, because if you are comfortable using IV epi, that's totally fine. I use it in adults when they come in with crashing asthma. IM epi is a great adjunct in these patients where you've already done everything and they're not moving air. Getting it parenterally is going to ensure that they actually get that beta agonist delivery to the lungs, open them up. And we see this all the time where you get that IM epi dose in, and all of a sudden the kid or the adult looks 100% better. That's exactly what you're going for. So really don't be worried about giving that dose of epinephrine, thinking, oh, this isn't really indicated. Why am I giving it as a shot? I should just give more albuterol. If the patient's not breathing, they're doing badly. Just give them the IM epi. That's a great message to take home. Now, all of this is really fantastic, but at least sometimes it's hard to kind of localize the noise. You said it. Some of these kids are crying and you're like, I don't know if that's stridor. I don't know if that's wheeze. I don't know if it's both. So when you can't really localize it, you're not really sure, how do you approach that kid?
You're right. It's not always straightforward. A lot of the times it's giving the child some time to present themselves, but that's also where our frequent reassessments come into play, right? You're not sure, you go down one path, it's not working, and you kind of reassess and do something different. So let's just talk right now for STIR or stridor. So if the patient is otherwise not ill or toxic appearing, you have time to localize. Is it coming from the nasopharynx, or is it coming from like the subglottic lower upper airway? Because your management strategies are going to be different. So it is, like I said, very hard sometimes to differentiate between stridor and stridor. Oftentimes they're febrile, they're crying, so treat the fever, suction, reassess. If there's really no change, it's probably stridor then, so go ahead and treat. But again, be sure to reassess for a response. Don't come back in 2 hours and the noise is still there. If the patient is between 12 months and 2 years, coming in with URI symptoms, expiratory work and wheeze, how do you tell the difference between your bronchiolytics and your asthmatics? They sound the exact same. Sometimes they look the exact same. So a lot of that is going to be your risk factors for asthma. That will help you. So do they have allergies? Do they have eczema? Is there a family history of asthma? But if you're still unsure, it's completely reasonable to suction, reassess, treat their fevers, and really, if there's no change, you trial that one dose of albuterol. But you have to look and you have to listen afterwards to see if there was any change. They might not be back to normal, right? They might still need the full set of treatments, but if there's any change whatsoever, then continue. Give your 3 back-to-backs, give your steroids, and continue using your tools along your asthma pathway.
All of this is really good for the run of the mill patient, but one of the things that we do have to think about are the zebras. And let's be honest, if a kid comes in with asthma or bronchiolitis, almost anybody can manage that patient. But as attending physicians, they pay us the big bucks to find the zebras, to find the patients who are coming in with the other 20 viral syndromes that have something different. This can be a real challenge to figure out which of these kids has something else, and we need to be taking a very different approach to taking care of them. So I know we can't go through everything, but what are some of the pearls that you consider when you go into a shift between, oh, let's say October and March, that high viral respiratory season, that you take into every room and say, I don't want to miss these things. I don't want to miss these zebras. So I'm always thinking about these things when I walk in.
We all in emergency medicine, whether it's adult or pediatrics, have our illness scripts. And it's like you mentioned, it's how we get through day to day. It's how we see so many patients and so many of the same. But it's important not to miss that needle in the haystack. If the history is concerning or if they don't respond to your typical treatments the way that you've seen in the past, the way that you would expect, then you have to start thinking of other pathology. It's when you go into every room with that well bias that this kid just has a virus, they're going to be okay, treat their fever, go home. That's when you're going to miss your sick patient, your zebra that you never want to miss. So, a couple of examples: the kid with cough and fever for 6 days, or a cough with acute onset fever, lung sounds are clear, they're febrile, tachycardic, they're tachypnic, they have a normal oxygen, and their vitals improve with antipyretics. These are both the right stories that could likely be a pneumonia. After all, we know that our physical exam for pneumonia in kids has very poor sensitivity, especially when referring to our clinical impression, presence of tachypnea, decreased breath sounds, or even rales. Go ahead and order that x-ray. The kid with croup a week ago who becomes incredibly stridulous, they're tripoding, they're overall ill appearing, they could have bacterial tracheitis. An acute coughing or choking episode who comes in now wheezing could not be asthma or bronchiolitis at all, but it could actually be an aspirated foreign body. And if you don't treat that foreign body and get it out of there, is only going to have further complications. Or what about the younger patient who comes in who's afebrile, they're tachycardic, they're tachypnic, they have some wheeze, but no significant work of breathing? It could actually be pulmonary edema with a metabolic acidosis from early myocarditis leading to CHF. So, as my mentor, Dr. Mojica, would always teach, while listening to what you assume is a routine bronchiolytic seems straightforward, always put one hand on the belly and try and feel for hepatomegaly. It's one of the earliest signs you may see. Myocarditis is often missed and discharged home until they come back with fulminant heart failure. And finally, an otherwise well appearing stridulous kid comes in with some drooling. Very important to assess the posterior oropharynx. Are they ranging their neck? Are they moving it side to side, flexion extension? Because could they potentially have an upper airway obstruction from something else that's not just croup? For example, a PTA or an RPA. And I could go on forever here.
It's funny, a lot of these tips sound so familiar, and it's because we share the same mentor. Dr. Mojica taught both of us so much during our training that we take to the bedside every time we see one of these kids. And these are little things that don't necessarily increase the amount of time the patient has to be in your department. We're not saying get x-rays on everybody, do POCUS on everybody, get EKGs on every kid, but take that extra second, the extra 30 seconds in that physical exam, in looking at the patient. That's what's going to tell you, this just doesn't look like the other 20 bronchiolytic kids that I saw this week. The kid looks different, and you have to trust that instinct. You have to trust that instinct and then say, well, I didn't get an x-ray in the last 20 kids with bronchiolitis, but this one, I think this one needs an x-ray, and go with it, right? Don't convince yourself out of it. You will lose sleep by doing that. Sometimes we just have to trust our gut. And it's also why waiting through viral respiratory season is such an important rite of passage for emergency docs. That's where we learn this is what a kid looks like with bronchiolitis or an asthma exacerbation or RSV. And then that's not what the kid should look like. So that one is the one where I need to do a little bit more. I need to get that chest x-ray, the blood work. Maybe I do need to take a look with a POCUS on that kid. All of these things can really help us to determine which kids fall out of that usual pattern. Elise, this was great. I feel like just looking at you on the video, you have like 20 more of these pearls, which will really help to improve the way we deliver care. So we're just gonna have to bring you back. We're gonna have to bring you back for some more of these pearls so that all of us can kind of have a little bit of a better approach to taking care of these patients, weeding out those needles in the haystack, and making sure that when we send these patients home, we send them home to a good outcome. Thanks so much for coming on and doing this with us.
Looking forward to having another opportunity to be here. So thanks for having me back.
All right, that's all for the Rebel Core Content Podcast this week. We'll be back in a couple weeks for another cast. And in the meantime, don't forget to pop on over to the site, check out all of the fantastic posts from our faculty. And until next time, stay safe.